About 6 months ago, when I was asked to first lecture in the Forward 2020 conference in San Francisco, I anticipated being in a conference hall with 300 or 400 people, shaking hands maybe 100 times during the day, hugging people who I've known for many years, going and having a few beers or a bit of a banquet in the evening. Perhaps the next day, talking to 30 or 40 students or more, and having a pizza lunch and discussing the future of research in the field of spinal care and chiropractic care. The world has changed in those 6 months and in the last few weeks. We've been locked down with social distancing for 6 weeks now, perhaps even a little longer, and we're not sure how long this is going to continue. We're in social distancing, still Zooming and having meetings 8 to 10 times a week, and doing podcasts such as this. So staying very busy, but at the same time being very active and in a totally different world. I've therefore elected to change my topic and to discuss it in more relevant detail. The topic I've chosen for today is the future is changing, but patients still need care. This is part of the Global Spine Care Initiative and the World Spine Care Program. Conflicts of interest always have to be presented at meetings like this, and I do have royalties from a number of textbooks, although they're getting a little old now. I'm a consultant to spinehealth.com. I get travel costs reimbursed for multiple conferences and lectures, and have research grants from the Skoll, Musk, and NCMIC foundations directed to the World Spine Care Program for the Global Spine Care Initiative. In this presentation, I've divided it into 4 parts. The first is, why do we care about spinal disorders and disability in a coronavirus world? The second is improving the lives of people in underserved communities through sustainable evidence-based spine care, the World Spine Care Program. The third is on the Global Spine Care Initiative, what it is and what it achieves. And fourthly, managing back and neck pain in the time of COVID-19. What do we all do? Or what should we be doing at this time to take care of our patients? The first part is, why do we care about spinal disorders and disability in a coronavirus world? I want to give you an example of a patient from Botswana and attended a World Spine Care Clinic. This is a 36-year-old hospital employee, for many years was happily married with 2 children, 11-year-old and 3-year-old sons. She presents to the World Spine Care Clinic in Botswana with 10-year history of low back pain that expanded to the entire spine. She could not care for herself. She had to get help to go to the toilet, bathe, and bend over. Could not make love to her husband. Her husband refused to take care of her and leaves. She moves in with her family and now have to take care of her. She's not able to work in the hospital and loses her job. No workers' compensation and no social net. She tries to start a business making jewelry at home to survive. She could not travel to sell her jewelry and could not take her care of her children or clean her home, which was filthy. But we must understand that it's not only her that is affected by her disability. Her employer has lost a skilled employee. Her husband loses the additional financial support for the family that she would bring in, companionship and conjugal relations. Her children stop going to school. The family is stressed by having additional 3 people to care for, and the government loses tax revenue. The World Report on Disability in WHO describes just how serious this is. They note that over 1 billion people in the world today experience disability, and that the primary causes of this disability are arthritis and back complaints. And it's mostly related to their ability to be mobile. At any one time in the world, according to the global burden of disease and other studies, over 1 billion people are experiencing low back pain. It is the #1 cause of disability worldwide, where neck pain is the #4 leading cause of disability worldwide. Spinal disorders, if one looks at the overall impact or burden, is greater than HIV/AIDS, depression, malaria, breast and lung cancer combined, stroke, diabetes, Alzheimer's disease, traffic injuries, or lower respiratory infections. It disproportionately affects the most vulnerable people in our society: women, the elderly, rural communities, the lowest income of the population, and in low-income countries. Globally, chronic low back pain has a point prevalence of 18%. That's 18% of the world at any one time will state they have low back pain. And according to Jackson in his recent paper, chronic low back pain in low and middle income countries is even greater at 21%. One fascinating piece of research I had the privilege of working on with Katie DeLuca in Australia was to look at comorbidities. Is spine pain an isolated symptom? Is it or is it associated with other disorders? Diabetes, cardiovascular disease, pulmonary disease, cancer, mental disorders, overweight, and obesity is all greater in people who have spine pain compared to those who do not. People over the age of 70 with back pain have been noting by Fernandez et al. In his paper, have a 13% increased all-cause mortality per year. And a study we are just completing and publishing now shows that cognitive impairment is substantially greater in people with neck pain or low back pain, and even greater if you have persistent or severe pain, and especially high, almost 3 times as much if you have both severe pain and persistent pain. That is the main reason why we have to think about it. Why do we need then evidence-based care? How are we going to take care of it? Well, one of the reasons we need evidence-based care is that there's considerably confusion out there. Let's look at the person or the patient who has a problem. They have limited understanding, limited education or literacy in spinal disorders, very worried about their ability to maintain their job, care for family, or have future problems. And the question they ask themselves is, what do I do? Well, we wrote a paper, or I wrote a paper, and spent a couple of weeks looking at all the treatment options available to a patient who develops low back pain. And what we found is that if you separated this into aisles, and you made one aisle pharmacological, another manual therapy, a third aisle of exercise, a fourth aisle for physical modalities, a fifth aisle for psychological and education, sixth aisle for injections, seventh for minimally invasive surgery, eighth aisle for surgery, lifestyle therapies, and complementary and alternative therapies. And if we just looked at what was being advertised in newspapers, television, telephone books right now, which a patient could look at, I could not fit it on one page. There were over 200 different treatment options available for a patient in Southern California who had low back pain. It was like being in a supermarket where you walked up and down these aisles. And the analogy is like this. A patient is in pain. Their cognition, mood, and coping is affected. They have numerous options to consider. The terminology is extraordinarily difficult and must live with the consequences of their decision. The analogy was that this is trying to make wise food choices when shopping in a foreign supermarket with incomprehensible food labels on an empty stomach. Well, what about the clinician and provider? Why do they care about evidence-based care? They have limited time to see a patient or answer problems, even in normal times. They have limited time to keep up with the latest research on each treatment approach for all spinal disorders. They have marked differences in education, understanding of spinal disorders, and especially spine pain. What a chiropractor knows is different, or learns, is different from what a family physician learns, is different from what an acupuncturist or a physical therapy might learn during their education program when they study spinal disorders. It is even more difficult today in providing care during periods of social distancing. So the question we all ask ourselves is, what do I do? What about the policymaker or the payer? They have limited funds available, but are responsible for ensuring care is available to all of their account holders. They have limited understanding of the value of spine interventions, and they rely on clinical directors who have training in only one specialty, perhaps a surgeon or a pain intervention specialist or a chiropractor. And the policymakers ask, what do I do? They have a problem. A recent paper by Haldeman in the Journal of the American Medical Association looked at 154 different conditions and the costs. Low back and neck pain had the highest amount of healthcare spending in the United States, with an estimated $134.5 billion a year. Other musculoskeletal disorders accounted for the second highest amount of healthcare spending at $129.8 billion. So what are we achieving? There was a paper a few years ago showing expenditures were increasing more rapidly in the spine care world in back and neck pain than in virtually any other healthcare problem. Prescription medication had at that time had increased almost 200%. Narcotic expenditures increased by 400%. Outpatient services by 43%, inpatient services by 87%, chiropractic costs by over 100%, and physical therapy costs at 78%. Now, you would expect that if we were throwing this amount of money on to try and find a solution for a problem, healthcare problem, that we would start finding some answers. They found, however, despite the total expenditures of increasing by 60%, physical functioning limitations in people with back and neck pain actually increased from 20 to 25%. The more we spent on healthcare and the increased costs, the worse health we were offering our patients and society. This has led in poorer countries to a default position. In South Africa, only 90% of primary care patients receive only pain medications. They don't see any other clinicians. In Iran, on the other hand, patients with acute and chronic low back pain go directly to an orthopedic surgeon, neurosurgeon, or rheumatologist. In other words, in the hands of a specialist, and usually an interventional type specialist. In Cambodia, 41% of patients with low back pain were admitted to hospital at huge costs. In Brazil, 53% of low back pain patients had visited an emergency room or been admitted to a hospital in the past 6 months. This clearly is not acceptable. It is this conundrum and this difficulty which led to the formation of the World Spine Care Program. The goal is to improve the lives of people in underserved communities through sustainable, evidence-based spine care. It is a non-profit charity registered in the United States, Canada, and the United Kingdom, with the goal of helping people with spinal disorders in underserved communities throughout the world. It's supported by the Global Alliance of Musculoskeletal Health of the Bone and Joint Decade. It is now recognized by the World Health Organization as a model of success, especially the Botswana program. It is listed under their Integrated People-Centered Health Services framework. It is supported by numerous professional institutions and endorsements, and has an institutional endorsement, and has multiple research collaborating centers on 4 continents. It has a prevention strategy, including scoliosis screening and exercise program, including yoga and straighten up program. It has conferences. We've had 3 conferences in Botswana and 1 in India. The last conference in Botswana was opened by the Minister of Health, had 300 attendees with 22 speakers from 10 countries. It was supported by the Ministry of Health and Welfare of the government of Botswana and a line of international spine societies. There are clinics now in Botswana, in a remote village of Shoshong in Botswana. There are clinics in a secondary care facility in Botswana in the town of Mahalape. And there's a clinic in the Dominican Republic associated with the research in it. At each time, we have had a memorandum of understanding which we signed with the government. And we have volunteers who come from around the world to participate and to offer care within these clinics. We've had over 50 volunteers so far who have gone to either Dominican Republic or Botswana to offer care. They spend anywhere from 6 weeks to 5 years, depending on how committed they are to the program. Each learns more. Each of these volunteers earn or see more pathology in 1 week than they did in the entire course as a chiropractor or physical therapist. There's a program in Ghana which we still are hoping to maintain because the need is so great there. And we have an ongoing clinic in India, in the Mahatma Gandhi Medical College, manned primarily by the physical therapy department in that university, but also establishing, or in the process of establishing, remote clinics. Each one of these clinics offer evidence-based care. I want to go back to Gasabomo. After 3 months of care at the clinic, she described only minor localized pain that she can control. Her husband is back and their relationship is back to normal. She returned back to her home. She can work and clean and cook and care for her children. She can lift her child without pain. She can sit for a long time and her children are back at school. She reports that God is alive and has a plan for my life. I am now a person. So the main challenge we all have is to address the problems of spine-related disorders and disability in underserved communities and low and middle income countries without reproducing the policies and priorities that have dominated spine care in high income countries that have avoided, and we have to avoid this marked increase in expenditure on treatment approaches that have no impact on disability or pain. This has been described in the Lancet in a series of articles last year, that in 2018, which basically laid out the problems of what spine care is currently dealing with. And the message they presented in these articles in Lancet was that we have to develop clear care pathways and develop consistent evidence-based clinical care in each country where we want to make an impact. This, and need, or obvious need, led to the development of the Global Spine Care Initiative. It's an initiative of World Spine Care proposed to create and reduce a research proposal to reduce the global burden of disease and disability by bringing together leading healthcare scientists and specialists, government agencies, and other stakeholders to transform the delivery of spine care in underserved and low-income communities. It hopes to develop and evaluate an innovative, integrative model of care to improve the management of spinal disorders. It is a multidisciplinary task force of 68 spine care clinicians and researchers from 24 countries. And the publication, its initial phase 1 publication was in European Spine Journal in 2018 and consisted of 15 scientific peer-reviewed papers. This is the list of the co-authors and members of the Global Spine Care Initiative. It was funded by the Skoll Foundation, the NCMIC Foundation, and the European Spine Journal. The 68 clinicians included specialist medical doctors, chiropractors and osteopaths, university and higher education teachers, epidemiologists, administrative professionals, physical therapists, general medical physicians, legal professionals, psychologists, and a number of others. So it was truly multidisciplinary. Of these, 58% had clinical experience in a wide spectrum of countries. It had, the members of the task force had treated people with spinal disorders in 36 countries across 6 continents. The initial phase 1 consisted of 8 different literature reviews to determine what interventions work and when. This included a review of assessment, non-invasive management of spinal pain, invasive management of spinal disorders, psychosocial management of spinal pain, public health and preventive interventions, and interventions for serious red flag spine pathologies. The methodology was a modified Delphi process once the literature review had been completed. It included 2 Delphi rounds and then a third consensus. After that, the consensus was almost 100%. What became evident, what came out of this was a series of papers, which I'm only going to be able to touch upon. One of the most important was that current diagnosis for spinal disorders simply doesn't work and rarely links to evidence-based care. What has been found that the current evidence suggests that it is best to simply divide spine pain according to symptoms that respond to specific treatment approaches. So we had a class 0, looking at the bottom of the page, which is somebody who has no real problems. They have prevention and concerns. Class 1 and 2 are pain-only symptoms. Class 3 is neurologic symptoms. Class 4 is spinal deformity, specifically spinal deformity that has requires treatment, including trauma, and serious signs of red flags or serious systemic disease. So the thought process was quite simple, that if somebody walks in your door, the first goal is to eliminate serious or systemic disease, or class 5 disorders. This includes cancer, infections, and other emergencies. If they are ruled out, you go to spinal deformities. This is primarily trauma, such as fractures, but also scoliosis might be included in this. Then you have to look at neurologic symptoms, strength, sensory balance, etc. If you eliminate those, you end up with 90% of the population, which is pain only. And we'll discuss that in a little bit. And then there's a series of people who have minimal pain, but are still very worried. And the primary concern here is prevention. It's recognized, however, that these classes, the simple description of red flags as being any serious pathology was not enough when you have to make a clinical decision. Because some of these class 5 red flags are acute and severe, and others are slowly progressive, and others are simply non-spine pathology, such as a kidney stone or aortic aneurysm. Class 4, or spinal deformity, may be stable and of no consequence or non-symptomatic, or could be due to a fracture or scoliosis and quite symptomatic. Class 3, neurologic complaints, may be non-progressive and actually may be chronic, and nothing is going to make them bad. But if they're new, acute, and progressive, that becomes an emergency. Class 2, which is moderate or severe pain, actually comes into acute and chronic, and is dependent upon the level of disability. A large number of people, a substantial number of people with spine pain, have only mild pain, but enough to be a nuisance, and they want it taken care of. And it can be either acute or chronic. And then for the general population who have no pain or minimal pain, you're talking about, are there risk factors or are there no risk factors? So the Global Spine Care Initiative, after it had set out these classes and subclasses, then for each subclass, as you note on the right side, linked this to the literature reviews to determine which treatments could be considered evidence-based for this presentation of a patient. And they are assessment, and then you should consider providing patients with certain treatment approaches and certain self-care approaches. I'm not going to go over them. These flashcards are available on the web, on the literature and on the website. And for each one of these, this is particular one, for example, is minor non-progressive neurologic deficits or symptoms. And in these cases, you may actually be willing to do some short-term manual therapy, which you would not even consider if you had an acute or progressive neurologic disorder. The next thing that became evident is that when one looked along the top line at the classifications and then tried to decide who should be taking care of these patients, it was to divide these care pathways or care management groups into 4 separate groups: self-care and community care for people who had minimal symptoms or mild symptoms and needed education primarily; primary spine care, which is somebody trained and fairly exclusively in the field of spinal disorders, would take care of some 80% of all patients who present with a spinal disorder, but would also be able to make the diagnosis and a referral to people, to specialists, if there was an emergency. In other words, to do triage and the management of patients that fall within their skills. Secondary spine care, it became obvious that these should not go to a hospital or medical specialist if you only have mild pain or something that does not require surgical or advanced medical or rehabilitation work. But they are necessary to take care of many of the spinal disorders or spinal symptoms that would respond, including progressive neurologic disorders and some structural disorders. And then you have tertiary spine care centers. And in these centers, it really is limited, their need is limited to very advanced surgery and very advanced medical care. But what was obviously necessary is integration of primary spine care, secondary spine care, and self-care and community programs. These have to work as cogs in the same wheel. So people are referred back and forth within this multidisciplinary, multi-level spine care world. This is not just something that the Global Spine Care Initiative and World Spine Care is thinking about. This is a movement within the world. And we see articles, for example, on the GLAD back spine education program, the National Institutes of Health and Care Excellence in UK, the Choosing Wisely initiative of the American Academy of Family Physicians, and the American College of Physicians with their guidelines, all follow very similar literature reviews and recommendations. What we're looking for is that we can give the right care to the right person, to the right place at the right time, where the majority of the world's population get the lowest cost, highest quality education to prevent spinal disorders. Primary spine care takes care of those people who need some form of care, but at a lower cost, and they are the most common. Secondary spine care is more moderate in its cost and requires specialty care, and we leave the tertiary and quaternary care to the which is the highest cost, for the most complex conditions. This brings us back to neck pain and back pain in the time of COVID-19. The World Spine Care Program and the Global Spine Care Initiative have brought together a team and presented through a consensus process a clinician and a patient guide. I'm only going to go over the clinician guide at this time, and we hope this is helpful. What we have found is that as a result of the COVID-19 pandemic, which many of you know have now killed over 75,000 people in the United States and over 250,000 in the world, primary spine care clinicians are unable, for the most part, to see their patients. This includes chiropractors, physical therapists, osteopaths, and family and general physicians. Many may be seeing emergency care patients or patients that have to be seen, but there's been a substantial restriction in the general care by primary spine care clinicians, which are mostly high-touch professions in the time of COVID. At the same time, secondary and tertiary medical specialists and surgeons have been forced to limit their practices to emergency cases. This includes orthopedic surgeons, neurosurgeons, rheumatologists, pain management specialists, and neurologists. Despite the difficulty in accessing a spine care clinician or a doctor for your treatment of spinal disorders, spine pain has not suddenly gone away. People are still experiencing back pain, neck pain, discomfort, disability, and disruption of their lives, and are still looking for help. They have not gone away. Patients are becoming increasingly anxious, and if we're not careful, they can become neglected if they're unable to see their primary spine care clinician. So we developed these primary spine care clinical guides as well as a patient guide. As a disclaimer, this guide should only be considered in situations where social isolation is required or where clinicians or patients have elected to reduce contact due to COVID-19 to those who require urgent or emergency care. It is expected that patients and providers will continue regular care as soon as any restrictions are lifted. The guide is provided as a public education service, and World Spine Care can't assume any responsibility for legal issues that may arise. This was, however, developed by 28 spine care authorities and clinicians from 10 countries on 4 continents. It consists of 5 steps and 3 addenda to the clinical guide. Step 1 is a patient demographic and psychosocial situation assessment. Step 2 is complaint severity and triage. Step 3 is a global spine care initiative classification or initial triage and differentiation of the patients. Step 4 is determination of the spinal disorder subclassification, and step 5 is treatment consideration. Addendum 1 is telehealth consideration, addendum 2 outpatient consideration, and addendum 3 is self-care recommendations. So let's look at this. Let's go through this fairly quickly because they are available on the World Spine Care website. Patient demographics and psychosocial situation. The first contact with a patient contacts me for a spinal pain and asks what they can do and whether they need to see someone. What can I do to help my patient without placing them at risk of COVID-19 infection? You need to have a patient demographics and psychosocial report. You have to know who the patient is, what the age and sex. You have to know what their employment status is. You have to know where their primary complaint is and what any comorbidities, and you have to take care of their psychosocial anxieties. How concerned are they, and how is this disrupting their life? In the complaint and severity and triage section, there are 5 questions. These are also included in the patient COVID-19 guides and can be compared, or the doctor can compare these with the patient's questionnaire. They should be reviewed with a patient. They are, what are the patient's problems or symptoms, usually using a VAS scale, or visual analog scale. Does the pain radiate on the spine? Are the symptoms stopping the patient from doing normal activities, some form of disability scale? Has the patient experienced a recent fall or accident? And is there any history consistent red flags for spinal pathology? In brief, what are the patient's problems? Minimal pain, mild pain, moderate or severe pain, numbness or tingling, muscle weakness, loss of balance, onset of bowel or bladder complaints, or loss of control, or recent onset or pre-existing and not changing symptoms. Does the pain radiate beyond the spine? No. Down both legs, down one leg, down both arms, down one arm, new or different headaches, chest pain. These are just a few, but these are the basic questions that should be asked of every patient. Are the symptoms stopping the patient from doing normal activities? No. They can do everything, yes, a little, or yes, a lot. The patient has difficulty doing anything. Has the patient experienced a recent fall or accident? The accident is yes and no. That is something that could make a decision, influence a clinical decision. Is there any history consistent with red flags for spinal pathology? No, or cancer, infections, TB, HIV, osteoporosis, steroid use, inflammation of the joints, serious neurological disease, and these days maybe some clotting factor descriptions as well. The third step is the spinal care initiatives classification. So once you've looked at this, you look at the answers the patient is given, and if they have minimal or no discomfort and no other symptoms, they're class 0. If they have mild spine pain, they're class 1, moderate spine pain, class 2, severe spine pain is the severe form of class 2. Symptoms consistent with nerve problems, class 3. Class 4 is possible spine or bone fracture, and class 5 is possible complication of serious pathology affecting the spine. Step 4 then is to look a little closer at this patient's symptoms. You simply have to ask 3 questions. What is the duration of the symptoms? Are the symptoms progressive or stable? And what risk factors for spine pain and comorbidities are present? This allows you to make some decisions. If you have class 0 with no history of risk factors, or even if you have history of risk factors, it's not necessary to see a clinician in his or her office. Telehealth may be necessary if there's a history of risk factors, because the patient may want to discuss these risk factors with you. Class 1 is mild pain with no significant disability. And they can be either acute or chronic. In these cases also, office-based treatment by a clinician is not usually necessary, at least not on an emergent basis. Telehealth, however, may be necessary, and advice and reassurance may be very helpful to patients to relieve their anxieties or any concerns they may have, and to give them advice on how to control their symptoms. Class 3 is divided in moderate and severe. If you have a moderate level of acute pain or a severe or chronic level of moderate pain, usually you don't need office-based treatment by a clinician. You might need it. It just depends on their level of anxiety and their level of disability. But telehealth is important. This is where you make your decision of what you do and where you advise and reassure the patient. These are also patients that probably require regular telehealth follow-up in order to follow them and ensure that they are progressing in a manner that you and the patient are happy or at least satisfied with. If you have acute, severe pain, that is pain that is causing marked disability, this is a case where office-based treatment by a clinician may be necessary. In many cases, you may, however, be able to manage it through telehealth in the absence of any red flags and if it's very acute. But these are the patients that you have to spend more time with, at least on the telehealth, and may have to see in your office. In the chronic pain and disability, office-based care by a clinician may not be necessary unless there's a flare-up of incapacitating symptoms. Under those conditions, you have to take care of those incapacitating symptoms. But I would always recommend that telehealth consultation be done first. If the patient has neurologic symptoms or deficits, and if they're minor and non-progressive, they just need following up. If they're chronic and stable, they've been there a long time and are not changing, they may not require care, and care may not even change them. But if they're acute, major, or progressive, you may require an office or emergency room treatment by an appropriate clinician, especially if you have disturbances, for example, of bowel or bladder function, or if you have marked indications to suggest a progressive radiculopathy or a myelopathy. Class 4, severe structural pain, spine pathology, and possible fracture. If it's stable, you don't really need to take care of it because it's not going anywhere, it's not doing anything, and it can be taken care of once the social distancing is over. But if you have someone with who's had acute trauma and you suspect a fracture, these patients require emergency care. If you have class 5 spine-related symptoms due to serious systemic pathology, and if it's severe acute spine pathology with marked red flags, you need immediate attention on an emergency basis. If it's slowly progressive spine pathology and you know about it, perhaps in the past because you've been with this patient before, it does require intervention, but perhaps not on an emergency basis. If you have symptoms originating from non-spinal pathology, for example, a kidney stone, aneurysm, or something similar, this requires emergency care. These patients have to be referred to a medical family physician or a specialist or to an emergency room. And the patient has to be advised that this is emergency. If we look at treatment considerations about anybody working in a coronavirus world, we have to follow World Health Organization, CDC, National Health Service of UK, and other national government guidelines and recommendations concerning the prevention and management of COVID-19. We have to use evidence-based treatment guidelines for each subclass of spinal disorders. You can use the flashcards or look at the NHS back pain, American College of Physicians, the Chiropractic Clinical Guidelines, American Physical Therapy Association Guidelines, or Task for Neck Pain Guidelines. All of these are references, and all of them are linked, direct links from the, when you download or look at the World Spine Care website. You have to advise patients over the phone and provide video consultations in some regions. Often these are becoming and increasingly becoming reimbursable under health insurance. You can use social media. You should be doing research. Existing online educational media satisfies the requirements for each patient. Some patients can only connect with certain media. Consider leading online education classes. You can go online with your patients and lead them in a class. Or consider leading or refer to online yoga. There are a number of yoga, Tai Chi, Pilates, and exercise group. And we also have links to these on the website. For class 0, class 1, and moderate class 2, reinforce that current symptoms suggest that self-care is usually enough to control symptoms. Provide advice and reassurance. Often may require multiple communications with the patient to relieve the pain. One point, the taking of over-the-counter medications, including paracetamol and non-steroidal anti-inflammatory drugs, including ibuprofen and naproxen, is recommended for short-term relief of back and neck pain by most evidence-based guidelines. However, these drugs are not benign. Patients should be aware of the potential adverse events, including gastrointestinal bleeding, ulcers, cardiovascular, and renal disorders. The possibility that NSAIDs may negatively impact COVID-19 pulmonary symptoms has been raised, but not confirmed at the time of publication, but simply the fact that it is a concern of many of our medical colleagues. It should be discussed with the patient, or at least the patient should be referred to someone who can discuss this with them. Reinforce the testing, such as X-rays and MRI scans, rarely help in the decisions on which treatment is considered in the absence of any red flags or serious progressive pathology. And referral to a surgeon is not necessary on an emergency basis unless the patient is incapacitated and has significant injury, which might represent a fracture, or red flags resulting in class 3, 4, or 5 assessment. Be available for follow-up. Contact with a patient on a virtual basis is absolutely crucial. You have to take care of your patients. Recognize that patients' symptoms change and follow up, and they can get better or get worse. So you have to ask these same questions each time you see a patient. They may fall into a different class or subclass and require different or more immediate care than originally recommended. And patients should be empowered to embrace self-management, but still feel they are cared for. Telehealth has its own problems. You need to find out if telehealth communication is allowed in your jurisdiction. You have to check with your malpractice carrier to be sure there are no restrictions for coverage while conducting telehealth. You have to make sure that you have a verbal consent from the patient in which they acknowledge there are limitations to a telehealth session, which is not the same as a physical examination. It is, for example, not possible to do a detailed neurological examination on the phone. You have to be careful not to violate any patient privacy rules. Use a video program or platform provides an appropriate level of patient confidentiality to satisfy regional or national laws. Find out if compensation is allowed, including billing requirements that may necessitate mandatory documentation regarding telehealth sessions with your patients. Keep records of your consultation. Be sure to get the address and physical location of the patient. It may be necessary if an emergency arises. Outpatient considerations, if the patient has to be seen in the office or other clinical facility, must be considered. Again, follow the World Health Organization, the CDC, or NHS and other government agency guidelines. Always wear a clean mask and gloves, wash hands before and after every patient contact, and may even want to wear a gown. With patients with severe incapacity or radiculopathy, especially if acute, They need to be seen in an outpatient office. You should also create a list of surgeons and medical specialists in emergency facilities in the community who will accept patients who require specialist care, immediate care. Some of the facilities in some towns and cities around the world do not have any additional emergency beds, and you have to find the location rather than simply telling a patient to call 911. And you prioritize frontline workers such as doctors, nurses, ambulance, and police. In conclusion then, spinal disorders are a huge health and economic burden that disproportionately impacts women, the poor, and older populations. During this pandemic, people still have spinal disorders. They still need evidence-based spine care. Chiropractors and other spine care clinicians can still take care of their patients while complying with distance restrictions. For more information, you can go to either globalspinecareinitiative.org or to the World Spine Care to download the guidelines of both the patient and the clinician guides. I want to thank you all. Thank you for the opportunity to participate, and also to wish everybody the very best and success. Take care of your patients, and I hope that we all get through this satisfactorily and can return back to a normal life. Thank you.